congratulations to you and to Mary Woolley and the entire Research America team for an extraordinary set of activities over the past 3 days. And I think you're right. This is a good set of challenges and opportunities to end on. We have in many ways more innovation, especially more innovative opportunities than ever before. But along with that have come some real concerns about access and affordability, about the effective use of these new and coming treatments, and especially equity, as we've seen worsening disparities emerge over the pandemic, building on some challenging trends over the last couple of decades. So I think this is a terrific group to bring together to discuss these issues. And I'd like to briefly introduce the panelists in a little bit more detail to set that stage as we get going. First off, as you heard from Derek, I'm Mark McClellan, and in addition to being the director of the Duke Margolis Center for Health Policy, I'm also an independent board member at Johnson & Johnson and Cigna. At Duke Margolis, we undertake a range of activities on exactly these topics, including support for the development of innovative care models that bring together telehealth, digital technologies, data and analytics, and new team approaches to delivering care, including meeting patient needs around social services, behavioral health needs through models like advanced primary care and specialized care models that include pharmaceuticals, whether it's for more of a prevention-oriented approach to COVID, which we really need, or more effective management of chronic disease. And we also do a lot of work related to coverage, payment, and better real-world evidence to promote the development and effective use of innovative drugs, biologics, cell and gene therapies. As I said, with many of these coming, there are important questions about their effectiveness in the real world for diverse patients and how to manage their costs and their impacts on the total cost of care. We're joined by Mark Reisenauer from Astellas Pharma. As you heard, Mark is president of Astellas Pharma's US, where he's responsible for the whole operations of Astellas. He also serves on the board of the Pharmaceutical Research and Manufacturers Association, PhRMA, which is the industry's efforts to engage on these policy topics. My longtime friend and colleague, Gary Puckrine, President and CEO of the National Minority Equality Forum, which is a non-for-profit organization that Gary founded back in 1998 to address the critical need for strengthening national and local efforts to use evidence-based, data-driven initiatives to guide programs for eliminating the disproportionate burden of premature death and preventable illness for racial and ethnic minorities and other special populations. Also, Cynthia Zagabolo, who is president and CEO of the National MS Society, as you heard, chair of the International Progressive MS Alliance Executive Committee. Cindy became president and CEO in 2011 and has long been working with efforts to advance care for people with MS, also a founding member and the executive committee chair of the International Progressive MS Alliance, someone who is passionate about building the MS movement and amplifying the voices of people affected by MS to policymakers and ensuring that the organizations that she leads can be an effective partner for them in their challenging life journeys. And of course, very important participant perspective as well is Peter Pronovost, who's the Chief Quality and Clinical Transformation Officer at University Hospitals based in Ohio. Peter is a world-renowned patient safety champion, innovator, critical care physician, researcher, entrepreneur, and thought leader who's done a lot of work, and we've had a lot of opportunities to work together on improving U.S. and global health policy. This includes work on checklists to reduce safety problems in hospitals, and in recognition of his work, he's been named one of the 100 most influential people in the world, and has also received a MacArthur Foundation Genius Grant. In his current job as Chief Quality and Clinical Transformation Officer, he's overseeing efforts resource in that entire healthcare system to promote ideas, and not just the ideas, but the implementation of new protocols and strategies for eliminating defects, increasing value, and improving quality of care as university hospital system moves, like many hospital systems are struggling to do today, moves into really shifting to a population health focus on keeping people well and intercepting the progression of serious diseases rather than just dealing with complications. So very pleased to be with this distinguished group today. I wanted to kick off with opening thoughts from each of you about how we can meet these challenges of continuing to encourage these promising innovations in medicine, but also addressing some of the concerns about access, cost, and equity along the way. So if we could start with maybe your big ideas or ideas that you'd like to see addressed, challenges that you're most concerned about from the standpoint of shifting our healthcare ecosystem to advance the future of patient-centered care, to help us move from the fragmented and, as Gary has said, sick care-oriented systems that we have today to focusing on keeping people well and increasingly anticipating intercepting disease progressions. Maybe Mark, could I start with you?
Sure. Thank you, Mark, and happy to be here. Thank you for the invitation. I think the issue of how we move more to patient-centric care in this fragmented system, this is an issue actually quite personal for me. And what I mean by that is, like many, I've been touched by having my father diagnosed with cancer a couple of years ago. And having been in healthcare my entire career, I thought I had a pretty good handle on just how to help him navigate his care. And obviously, this is a complex disease with a lot of different physicians and specialists involved. But I myself was overwhelmed with the complexity. The coordinating and navigating of the care, there's really no roadmap, and there's not necessarily a lot of support. So I think every patient has their own journey. They have their own perspectives and needs, and that needs to be understood. And it's not just patients, these are people. So at Astellas, we believe that every decision that we're making should contribute not only to patient health and caregiver needs, but also to help to advance overall care. And we actually, the way we think about patient-centric care, we think it involves a deep understanding of their experience, their medical need, and the behavioral drivers of care. We actually have a patient centricity department within our company. And I think what's interesting about this group is that their scope and remit is really the whole value chain of drug discovery, development, and then commercialization. And so we try to incorporate the patient perspective in all of those areas. And we believe that by taking their insights as we move forward, it certainly is going to help us to deliver better products and better outcomes. And I think what's interesting is not only is it in the very early stages and even early development and protocol development, but all the way through to the very last kind of stages around access, having to do with either market access or distribution. So thank you.
Mark, that's a pretty ambitious set of activities. Can you talk a little bit more about how you've seen that patient centricity focus influence your R&D and activities to bring products to market? Has it affected the disease areas you're working in? Has it affected the way you're approaching studies or pricing issues?
Yeah, great question. I think I'll give you a couple of examples. It does impact a number of points along the way as we progress our drugs. I would say in terms of the R&D component, for us, it's around the execution of the trials and looking at, it's funny, even simple things like protocols, and are they designed in a way that actually makes sense from a patient perspective, and how is that experience for them? And making sure that if we do that right and we have their perspective, hopefully we have better compliance with the protocol and are able to enroll more patients. On the back end around distribution and access, we're always looking for new ways in which we can help patients access their therapy. And I think one example is even with the recent pandemic that we're in, we made some changes on the fly as we saw that there were more patients in need who didn't have insurance or had other reasons where they couldn't access their meds. So we made changes to make it easier for them to access our patient assistance programs. And not only did we do that, but we also looked at the criteria for who could be enrolled, et cetera. So it's something that not only is it something that spans, but it's also very timely in that if we have changes that are occurring real time in the marketplace, we're also looking for what the need is and how we
Right. Thank you. And next, again, help us kick off this discussion. I'd like to turn to Gary. And Gary, I know from our longtime interaction on these issues, it's been a set of topics that you've been primarily concerned about for many years, and really the impetus behind the National Minority Equality Forum. What's top of mind today?
So, I'd like to start with what I call battlefield awareness. So where are we on the battlefield of healthcare? I think our future is that we're coming to the place where we're going to be able to control health outcomes. That a lot of the chronic diseases that have been plaguing mankind forever are within sight. Not to say that they're going to happen tomorrow, but the medical revolution is in full blown. And the challenge is that we are really not prepared for that revolution, that a healthcare financing system is 20th century model, and even more importantly, that legacy system was born in an era when inequalities were acceptable in society. And the conversation we're having today is that we want to eliminate those old inequalities and make sure that every patient who comes into the healthcare system gets access to high quality care. My point being is it's time to reimagine the healthcare system. We have to give ourselves permission to rethink our healthcare system. And I would contend that the place I would start is really to build it around mitigating patient risk. Every patient who comes into the healthcare system already believes that the healthcare system is going to mitigate their risk. It's going to keep them out of the hospital. It's going to keep them from the emergency room. It's going to keep them from disability. It's going to lower their chance for dying, and it's going to improve the quality of life. That is the expectation of everybody who comes into the American healthcare system. But we fail them. We're not proactive. We have the sick care system that we allow people to end up more severely ill than they need to be before we intervene. So we have to start again. And I think we're at that moment. It's difficult, I realize, it's a confusing place. So at the National Minority Equality Forum, we found, I think, a point in the system where we want to try to make that change. And we called it stage shifting in cancer. So with more in minority community, we get diagnosed late stage for cancer, and getting diagnosed late stage means that the mortality rates are higher, and et cetera. There's some new technologies that are coming on stream, these blood biopsies that are going to have the ability to allow us to diagnose cancers before we're symptomatic. Now, I'm not saying the science is there, because it's not, and we got to build around it in terms of therapies and all of that. But the point is, we can take that moment to try to build around the science and policy to make sure that we are shifting from late stage diagnosis of cancer to early stage. And I think if we can do that, now it's going to be a big push because I think there are a lot of policy barriers in the way because our system is built around financial risk. So it wants to manage financial risk, and we're going to have to push back on that. But I think the time is here. And we cannot go into 2050 standing where we are right now, we would lose the battle. And so that's our sense of where we are in NQF.
Yeah, it sounds like complements what we've heard so far. And in terms of taking on that shift away from, as you said, managing financial risk to really focusing on people's risk and moving upstream, any particular areas you'd like to highlight as we get this discussion going?
I think what I would say is we have to think of healthcare as an investment in the same way that we invested in the internet and highways and bridges. We invest in healthcare. And what we're trying to do is make sure that the next generation doesn't have to deal with what we have to deal with. It costs money. One of the things I was reading a book on World War II, and Eisenhower was going into Africa, and in the early stages of that war, it was a complete mess because the Americans weren't battle ready, but he had the resources to overcome the mistakes, to learn. And that's what I think we have to do in healthcare. We have to understand that this is an investment. There's going to be money spent, but at the end of the day, the next generation won't have to deal with what we deal with.
Yeah, it's important. We've had a lot of discussions about inadequate infrastructure recently, but this is an important take on that, Gary, with building that infrastructure for early diagnosis, validating screening, and then having the health systems that can get people into appropriate treatment much earlier than we're doing now. Great points to lead with. Cindy, could I turn to you next for some opening thoughts?
Great. Yeah, I'd like to build on a couple of things that people have said, and think about that important balance of innovation and access. And we can use MS as sort of a case study. The innovative MS medications have transformed the treatment of MS over the past 25 years. It's really incredible. There's been more progress in MS than any other neurological disease. Yet many people with MS cannot access the medications or stay on their medications due to the cost to them. And they are constantly working with this risk of something being taken away, or the financial assistance they're receiving cutting back, or if they change insurance, something changes. And so it's a real stressor for people. And this is a chronic disease. They're on these medications for a very long time. People with MS have limited access to the right therapy for them based on affordability. And the MS Society, we funded a study on the US economic burden of MS. The study will be published soon and will provide the most comprehensive assessment of the total financial burden of MS to date. We found that the medication to treat MS is the highest direct medical cost for a family. And ensuring access means more than it's just on the market, that it's just labeled. Access means that people should be able to get the treatment they need without financial hardship and without having to jump through hoops. It shouldn't be a full-time job for people to get on the medications they need. And we're finding that stressor of getting on that medication that they and their doctor choose to get on, that think is best for them, is enough to make you sick. So we need to have the nuanced conversation about what is truly innovative to a patient, to a person. And innovation dollars in the MS world would be best focused on a new drug class rather than options for an existing class, increasing options. In MS, the prices of medications just keep rising, even for therapies that have been around since the mid-1990s. The prices of those therapies goes up. And with every new drug, we have 20 therapies on the market now. As new therapies become available, the price of competition. We need to find a better balance between innovation and affordability.
And Cindy, great points. I just lost you for a second in there. I wonder if you could expand a little bit on, I take your point about the prices seem to be high, not just for the new innovative therapies, but ones that have been around for a while. Are there some particular initiatives or promising ideas that you all are focusing on to change that?
Well, we've been working on this since 2016, really talking about the challenges of the lack of transparency that there is in the world. We believe that all the players need to come together. The insurers, the payers, the medical professionals, the pharmaceutical companies need to all come together and talk about what's in the way of people getting what they need, of the therapy that's right for them.
Right.
And
Mhm. And I think we'll probably come back to a range of perspectives on this topic. I really appreciate your teeing it up so well. Next, Peter, heard about a range of perspectives on the problems and directions for doing something about it. How's it looking from where you stand? You're on the ground in a delivery system trying to really transform the way that care is being delivered to address these kinds of challenges.
Yeah, thanks, Mark. And I agree with all these points. Maybe I'll share with you some kind of ground truth of what we're doing, because I think it's humbling but yet hopeful. In our work on infections, that used to kill more patients than breast or prostate cancer, that are now down 90% in the U.S. The secret lesson of what led to that wasn't really a checklist. It was the stories people tell. Clinicians used to say, these are inevitable and there's nothing I can do about it. And they got reduced when they say, no, they're preventable and it's my problem. And we started to align our health system, which previously was completely RVU focused and what I would call reactive and transactional care rather than proactive and relational care, to say success is keeping people healthy at home rather than healing in hospital. And that the narratives that we need to change that are to say, stop believing that these, what we call defects in value, are inevitable, start believing they're preventable. Stop believing that it's someone else's job to do this, that it's your job and every one of ours, and stop believing that economic incentives alone are the solution, and we have to work together to design systems. And those defects, Mark, I'll share with you, a couple of examples of, we organize them into defects in staying well, so health behaviors, preventative services, immunizations. Defects in helping people get better. And part of our mantra is a key principle of making these defects visible. So take diabetes. 40% of people aren't diagnosed, and minorities, it's much worse. 11% are on the life-saving new therapies. 8% have their A1C and their blood pressure controlled, and about 90% have avoidable ED visits. Half of the people have a behavioral health need, and most of those aren't diagnosed, and maybe 10% have it. But all of that is invisible except to the patient, right? They're the one who's suffering, but in the care systems. And so we designed some key principles to say, let's define and make these defects visible. Let's design care around patients' needs, and let's develop a management system to make sure that we reduce those for everybody, because we think in doing this, we'll make sure that we address inequities. And a couple of examples, Mark, that I'm so hopeful for. Take diabetes care. We weren't doing particularly well like the country, but what we found is our endocrinologist said, it's a waste of my time to see patients for RVUs in a clinic. I see low value patients. So we supported them to go coach primary care doctors for every uncontrolled diabetic and make them have access to drugs and or an educator or a nutritionist. We went from about 20% on the right medications to now 85%, and every patient, or 85% of the people we see, we change their medicine. We couldn't pay for that because our pro fee didn't do it, but the hopeful piece is we went to several large insurers now and said, hey, we just proved this works. Would you do a pro fee cap to cover the cost of this, physician services? It's a much better model. We did the same for behavioral health, Mark, where when we designed around patients' needs, we saw that, we had this care system organized around specialists, but when we looked at what patients really need, about 60% of behavioral health needs are met by a social worker. And so we deployed them. The next 30% could be met by what we call this access clinic. That is a televisit for up to 3 visits just to get a diagnosis and treatment plan and get you back into care. And then the rest are cared for with chronic behavioral health and these behavioral health hubs. We went with essentially adding about a half of an FTE of psychiatry time, but just reorganizing to having virtually no access to behavioral health to now all of our primary care. And we aligned all of our health system to say, your job is to make these design care around patients, make defects visible and eliminate them. And Mark, I'm just delighted to and almost ecstatic to share. We just got our 2020 MSSP data, and from 2018 to 19 to 20, our Medicare spend has been reduced by 20%. I mean, it's like breathtaking, from about 10,389 to 2,286, while our quality scores have gone from 73 to 100. And the hopeful part, Mark, is like, we're still riddled with defects. I mean, like if you look at all these things about
still a lot more room for improvement.
Yeah, a ton more room for improvement. So I'm not sure how good we can go, but I think this concept that we're doing is onto something.
Yeah, it sounds like it. And if I could just follow up, and then Gary, I'm going to go to you next, because it sounds like it fits very well with the directional change that you are advocating. You started out by saying it's not just about the economics, but you're really taking a systematic approach here in terms that I think clinicians and normal human beings can understand around avoiding defects along the way. And that's a very aligned with what we heard from Gary too. But you did emphasize that the resource allocation needed to change. You were getting paid on sounds like a fee-for-service RVU basis, which does pretty well for those referrals to specialists for people with a poorly controlled diabetes, but probably not so well for the digital supports, the phone or other coordination between the specialists and the primary care docs, make sure the right diagnostic and treatment approaches are used in the first place, building in those additional team members, the social workers, the additional support for behavioral health. Can you say a little bit more about how you've made that sustainable and make it so much easier, it sounds like, for the clinicians, once they see the big picture, that they not only can work together to solve these problems, but they're going to get support for doing it. How you made all that come together? Yeah,
great. Mark, we call these care of chronic diseases systems of excellence because it involves, a variety of clinicians. And when we first introduced this concept of defects and value, some clinicians bristled. And what we say is like, we're not saying it's people problems, they're system problems but the end result is we're making decisions that are harming people, that are inducing suffering, that are adding waste. And we worked with many departments to say, okay, let's take a patient's journey and where are their defects and value, that if we change the behavior, we could change it. The way we made it sustainable, Mark, and this is a journey, is we pilot tested them in our employee health plan. So for the behavioral health and the diabetes, we started with, I bought a chunk of time for several clinicians to say, you're wasting your time seeing these patients. Go coach primary care doctors, or go review our employees who aren't controlled, and sit with the primary care docs and make sure that the patients have access to education, to a nutritionist, and that they're on the right medicine. And they could do like 10 patients an hour. So then we developed the business model and said, okay, that program as a pro fee cap is maybe around, $2,000 or maybe $1,800. So we went to some insurers to say, hey, like the way you're paying us for diabetes care is going to keep having defects in value. It's not meeting any of our needs. We won't have the specialist care as a pro fee, but could you do a pro fee cap for a group of your uncontrolled patients? And we did the same thing for diabetics with cardiovascular disease, where we set up a more intensive cardiovascular clinic. The behavioral health we were able to cover with pro fees. But Mark, what I've often found in these innovations is many health systems we need to drive value and keep avoidable readmissions out. but often covering the professional fee services is a barrier, right? Because it's often a different company or a different line of business. And the clinicians say, well, I can't do this if I don't get my time covered. And so I think these innovative ways of partnering to say, maybe do a pro fee cap. And as we learn more, Mark, I'll give you another exciting example that we did for the 1% of patients that are, 50% of our cost. We've really struggled, and we set up a clinic to care for them that's staffed by a psychiatrist, internal medicine, nutritionist, and social work. And what we found, Mark, was fascinating, that the strongest predictors of next year's high cost are seeing 4 or more providers if one's behavioral health, having either obesity or eating disorder diagnosis, and having a behavioral health issue. And when we started meeting with these patients to understand their life story, they all had multiple complex problems. They were seeing multiple clinicians who never talked. What we instantly found, Mark, was that where anxiety was viewed as a side story, it is the entire story. I mean, literally, we have like 50 patients, 30 of them who are in the ED every week. But the main driver was anxiety spectrum disorders that led to either underuse of services, so their diabetes weren't controlled, or overuse of services. And when we addressed that anxiety and disorders, we were able to then finally address their medical conditions. And literally, we have probably 30 people who went from a week in the ED to now going months. And we're too early on the cost data, but this seeing them holistically and putting behavioral health in the foreground rather than background is hopeful. We think as we get more data, we'd be comfortable going at downside risk. But right now, I think a pro fee cap to build the programs that drive value is, I think, the step we are on the journey.
And as you said, you've got some of the financial and outcome support data to show that that journey is really working. And it's nice to hear that there is a way to match up the notion of actually engaging the patient around what's most concerning to them, tying it back to what matters most to clinicians, and trying to help people improve their lives, connecting that to the supports needed to get a new system of care in place that can really work. I know Cindy, we are going to go back to Cindy in a few minutes, but I know we heard from her about just how much that's absent right now for MS patients who are just worried about getting access to their medications, or not really feeling like they're part of a well-coordinated health system built around them. So I do want to go to Cindy to talk about that, but let me first go to Gary, since I think there's an interesting fit maybe between what we just heard about from Peter in areas like diabetes care, where we do have the technologies to do early diagnosis and screening and effective therapies for those patients. We just haven't had systems set up that connect, that meet patients where they are and get patients into them that are sustainable. Gary, you talked about an emphasis on cancer, where we're seeing, just like in so many other areas, large health disparities that are counted in significant part by failure to this early upstream access in care. We're now in a moment, if you listen to every leader in the current administration that's focused on improving healthcare delivery systems, whether it's the Secretary of HHS or Chiquita Brooks-LaSure at CMS, or Liz Fowler, who's heading up the innovative care models. Every person has highlighted the importance of getting to earlier access to prevention-oriented treatments built around people with a special focus on addressing health equity. I know you've done a lot of thinking about the kinds of data and other kinds of health system engagement that are needed to fulfill the vision that you laid out. It seems like it kind of fits with what Peter was talking about, except that we don't quite have as much of the science there. And it's like early diagnosis for cancer. We've got 4 areas for common cancers where we do fortunately have screening tests that work quite well, evidence-based, for people who have access to them, but that's not most cancers and a lot of the cause of death. So if what Peter said fits with the direction you want to go, maybe you could help us put these together and tell us a little bit more about how we could use what seems like a really special opportunity to address health equity in the process. Gary, I think you may be on mute
Yeah.
still.
Yeah, sorry about that. What Peter was talking about was a healthcare system with purpose that was looking for defects. That's not the norm in our healthcare system. Lots of people walk into a healthcare system that is completely disorganized in the sense of managing their risk. And so that's exactly what we're talking about. We could save so many lives with purpose. If you take diabetes, for example, I look at the data in diabetes in the Medicare program, 60% of everyone with diabetes in the Medicare program goes to the hospital every year, either the emergency room or inpatient stay. There's no purpose to that. I mean, we actually can do better than that. An African American with diabetes and ischemic heart disease has a 90% hospitalization rate. Why do we have to have a 90% hospitalization rate? So the point I'm making is, Peter is unusual. He's in a system that certainly with his guidance and leadership is bringing purpose and helping patients. But most Americans go into the healthcare system and it's not structured like that. Nobody's looking at the defects. The conversation is really about financial risk. How do we cut payments here or there? And I just want to say one thing about this conversation about drug pricing, for example. Our healthcare system, in terms of organizing around clinical trials, is completely non-existent, right? If we built a real healthcare system in which we brought clinical trials to community structurally using a digital system so that we could recruit quickly patients into clinical trials off of electronic health records, et cetera, we could bring down the cost of medications, because that's one of the biggest costs in medications is the clinical trial research, but yet we still have not taken that on. And it's just another place in the system where if we reimagined it, and we have the capability to do it, we could wake up tomorrow and say, oh yeah, we're gonna link the research community to our clinical community clinics and drive down the cost of recruiting for clinical trials, and we're going to get better outcomes for patients. So there's just lots of places in the system where if there was a little bit of thought given to it, we could do so much better.
And it does sound like, Gary, the kinds of changes in the way we pay for healthcare that Peter was talking about would help with accomplishing those goals too, would really help put more resources into tracking patients, reaching out to them rather than for waiting for them to come in. Maybe you could say a little bit more about that.
I would just say this. I think if we built our healthcare economy around managing patient risk, it would not only benefit the patient, it would have us all invested in each other's health. And I think that would be transformative. It would give our society real purpose. And I just think the culture that would come out of that would be so profound. And I just think we have the opportunity to do it. We're just not taking that on.
Okay, I do want to come back to the rest of the panel for their thoughts about what else we can do to get there, because as you say, we seem to be making some progress. There's some great stories to tell, like what we just heard from Peters, but those are still the exceptions, not the norm. I do want to come back to Cindy and I'm sorry, having a little bit of technical issue here. Coming back to Cindy and Mark around the issue of drugs and innovation, how to fit that in. So Cindy, I know you appreciate and hopefully we'll get someday to the point where we can do early diagnosis and preventive intervention so that people don't progress to the point where they have debilitating MS symptoms. We're not that far upstream with the technology, at least as I understand it, with MS yet. Maybe there's some steps we can take to get there. But I'm wondering, your opening comments were just all about stress and anxiety, not just about the symptoms from the disease. Have you seen any good care models, or can you imagine what one would look like that would help people who are unfortunate enough to have a debilitating condition like MS, to have a better quality of life and get the care they need much more efficiently? It doesn't seem to be what's happening for most MS patients today, including issues around the drug prices, but back to the fragmented nature of our healthcare system, and one that doesn't help anticipate and prevent problems.
Well, there's not one solution, right, to all these diseases. And I think I would like to make sure we acknowledge that for some chronic diseases like MS, a person can do everything right. They can take care of themselves, their mental health, and live a great lifestyle and still have disease progression. It's an important point that the issue about sick care versus well care, the system that is designed to treat somebody who's sick or getting worse and to wait until people get worse. In MS, we know, and we have this data that early diagnosis and treatment with an MS drug therapy, with the right one for you, is the best way to shrink this disease, to minimize progression, and time is absolutely of the essence for people with MS. The scientific research has led to success, great success, in minimizing progression of disease and making MS a smaller disease. But when people can't get on the therapy for their MS because of the cost, or because of the insurance imposed step therapy, or because of the time-consuming self-advocacy that is often needed to gain coverage, the disease is progressing and you can't walk that back. Disease progression in MS means irreversible damage to the central nervous system, to the brain. And as people have to wait for weeks, for months, for years before they can get on the treatment that's effective, if they have to just go by trial by error and wait until something fails, then they're getting worse for no good reason. They're accumulating central nervous system damage, and we need to make sure that people can get on a therapy early and get on the right ones. Wellness and prevention are important factors in MS, and what that means in MS is getting the right therapy, making sure it's available and affordable, and getting on it earlier, and being able to stay on it while you're managing your healthy lifestyle and addressing those other comorbidities and things that can also affect disease progression. But the getting on the right therapy is critically of utmost importance, and it cannot be minimized in MS.
Yeah. And Cindy, have you seen any care models out there, since we focus a lot on this in this session on telling good stories of success, since clearly there are these huge gaps throughout most of the healthcare system between where we are and where we'd like to be in terms of innovation, access, and shifting upstream in terms of a prevention-oriented healthcare system, including prevention of the progression of MS. It seems like fitting back into Peter's model, this would be a care system that would get the data needed on an individual patient early, might be less focused on just visits for complications, might be able to engage, get paid differently, engage with the treatment developers in a way that helps to match therapies more effectively and focus more on getting those outcomes, preventing the defect of MS prevention. Are we anywhere on getting to those kinds of models?
Well, I think the research that we're doing in trying to address these issues of getting people diagnosed very quickly and on the right treatments quickly, there is some additional research that needs to be done about that. But there's also heightened awareness and understanding of how to diagnose MS, who gets MS, and that anybody can get MS. And this is one of the things that we get in the way. I think Gary mentioned some of the inequities that can occur. Sometimes people are not screened for MS. We're not looking at that. Because it's assumed that certain types of people maybe don't get MS. And that's a problem. That delays diagnosis. And again, when you delay diagnosis in MS, when you delay that diagnosis in MS, the disease is getting worse, and it's not reversible, and it could be preventable if people could get on the right therapies sooner.
Mark, if I could just add, because I think what you said, I mean, Cindy, and maybe we could follow, like, this is exactly right for one of the many things to say. If we rethought and said, design MS care with patients around their needs, right?
Yeah.
And then put the metrics based on the gaps in those needs. I mean, this isn't rocket science. Like we could see about, time from diagnosis to treatment could be a really key metric to make visible
Absolutely.
and call out to people, right? Availability of coordination or support services, access to behavioral health. And then you design it towards that way with, when it's not there, you make it visible as gaps. And I think, that's the kind of approaches we've been too organized around specialty physician, designing it around their needs and not around what the patient's needs. But I think the approach we've said could apply to a wide variety of things.
Well,
Yeah.
we also need to address the formularies of the payers. So it shouldn't be an insurance company that decides what therapy a person with MS can get on. And oftentimes that's what happens, because because they develop their formularies and they don't pay for certain types of medications. So having a system that is transparent in understanding, so a person knows and their doctor knows that, first of all, this is the best therapy for me, and this is what my insurance company will pay for. And when I purchase this insurance, I know what they're going to pay for, and when that's available to me, so that I can get it easily, and it won't be interrupted for changes in formularies or other things that can happen.
Yeah, Mark, maybe I could go to you, since in this example, it's kind of the nub of a couple of the comments in the chat too, from Michelle Williams and others, that, on one hand, I appreciate what Cindy's saying about, gosh, these step therapies, starting with just the cheapest approach, doesn't really match this strategy of getting the right patient on the right drug from the start to get to zero defects or get to minimizing progression. On the other hand, a lot of drug pricing and marketing seems to be about volume and about high prices. I know at Astellas, you all have a lot of life-changing drugs. You're doing a lot of work to try to target those drugs to the right patients through learning more about them. And again, not really about volume, but I'm just not sure how well our current payment rules for drugs on both sides, the pricing on a fee-for-service basis on the one hand, the step therapies and utilization review that comes in on the other, really helps us get there. And any thoughts you can add about, especially for conditions like MS, where the breakthrough and emerging drug therapies and potentially cell gene therapies and others are so important, how we can do a better job of getting value and avoiding the kind of situation that so many MS patients are in today.
Yeah, it's certainly multifactorial, but I think one of the ways to look at kind of the access and affordability is, and it's been touched upon, I think, by many of the panelists, is that you can look at, for one thing, you can look at benefit design and start there, because that's where I think a lot of the challenges arise. And let me give a specific example of one of those areas, which is Medicare Part D. So this was, it's been a tremendous success, no doubt about it. And it was created to ensure access for seniors and people with disabilities. But it was also created at a time when most of the medicines were for chronic diseases, and it was for large patient populations. And as the science has evolved, and we've gotten to more specialty diseases where you have more complex therapies, that there hasn't been a commensurate evolution of the benefit design in Medicare Part D. And I think where the rub comes is, so there's a lot of discussion, as we all know, in Washington about pricing reform, et cetera. And they want to start dealing with some of these issues in drugs and Medicare Part D. But that also comes at the cost of innovation and being able to target smaller diseases where actually, I think, Gary, I love Gary's line. You said it so eloquently. I wrote it down. It was so good. The medical revolution is in full bloom. That is exactly what has been happening. And it's been happening in very small disease areas as well for small patient populations. But that's, I think, what's at risk with some of the policies that have been discussed. And I think it's also being understood that when you look at some of the reforms that are being suggested, it will impact innovation and result in fewer medicines. But, I think turning that around, so what can be done, I think when you think positively, what can be done, I think Astellas and others have been advocating for some changes to the Part D design that we think would be significantly helpful with respect to access. And there's three kind of simple tenets. One, let's put a cap on out-of-pocket costs. And currently in Part D, there's many patients who just go on and on with their expenses, and Cindy references that. The second is let's smooth those costs evenly throughout the course of the year. Currently, the way that is designed, a lot of the costs are front-end loaded in the year. And we know that when costs get above about $250 per prescription, you see adherence drop off dramatically. And then lastly, but certainly not least, we as an industry negotiate significant discounts with the payers. Unfortunately, that doesn't make it down to the pharmacy counter and reducing the cost of their meds. So we would want those discounts to flow all the way through to the pharmacy counter. And there's other things that we're certainly advocating for as well, but I think that's one of many things.
Yeah, I just so one more follow up here, and then I can't believe we're already almost at the end of the session. I want to ask everybody to think about some closing comments that keep with the spirit of, okay, I know tons of things are wrong right now. I know there are a lot of proposals out there that don't seem like they're going to really fix the fundamental problems. But what can we do, as Peter and as Mark was just saying, and we're not going to get all the way to where we'd like to be tomorrow, but there's some steps we can take in the right direction, whether it's professional fee caps that are oriented towards outcomes and results for particular patients, or Mark, in your case, some changes in the Part D benefit. If it seems like what we really want, I know you've worked on this at Astellas, getting the holistic care around each particular kind of patient. They're getting more and more differentiated based on their risks, the medical opportunities for addressing their particular combination of diseases, which particular type of MS they might have, for example. And we're just not focusing on that very well. So you mentioned a couple of changes in Part D that could help get there. The out-of-pocket limit certainly would reduce some of that patient anxiety and enable the patients to focus more on what matters for them. Along with that, some of the bipartisan proposals for Part D reform, as you know, would shift some of that financial risk onto the insurers and onto the manufacturers. They're kind of all in it together to try to get better outcomes and lower costs. So that seems like that starts to move in the direction of alignment around holistic care around a patient. Does that sound like the right direction? Do you have some suggestions or cautions about how to build on further progress there?
Yeah, I'll take a stab at that. I think it's definitely a step in the right direction, because I think this is the crux of I think a lot of the issues is the access. There's great innovation, as we've talked about, but it's meaningless if patients can't take it. And this is not, unfortunately, our whole ecosystem is so interconnected. I think where we get into trouble, and this gets back to holistic, where we get into trouble is when we try to isolate in a vacuum one part of the problem. It never is one part of the problem. And so this is why, not only is it benefit design, but I think, as said even more eloquently by Peter, it's looking at the entire cost of care. Because if you're actually using some aspects of the healthcare system correctly, you should be reducing costs down the road somewhere else. But are we measuring that? Are we reflecting that value? And are we incentivizing all the stakeholders in the ecosystem in the right way towards that?
Great. Thanks for that path forward. I appreciate it. I'd like to go next to Gary. I've got about a minute or so for some final words of wisdom on how we get from where we are towards the kind of holistic system that all of you are advancing in one way or another.
I'm optimistic that we're going to do that. I think there's a lot of change coming in the healthcare system, the diversity of it, for sure. Back in 2008, 48% of African Americans had no health insurance. 54% of Hispanics had no health insurance. They're coming into the system. They're looking for quality care. And so I'm optimistic about it. And I think from an NMQF perspective, as I said before, we're going to focus on stage shifting and trying to use that as a leverage point to show that we could actually build a healthcare system that looks at patient risk and tries to figure out how do we mitigate it.
Yeah, and I really appreciate your point too about building more efficient ways of developing evidence, conducting trials much more on the front line in the community with better data systems, with point of care trial capabilities. That should be possible to do. So thank you very much. Cindy, does this address some of your concerns about what sounds like a very challenging state of access to care and precarious from the standpoint of further innovation in MS? And you're on mute, sorry.
I'd like to add to the conversation. We rely on innovation to find new treatments. It's really important. And we've had great innovation in MS. There are 20 treatments available, but we have to talk about innovation in terms of innovation, new class of treatments versus incremental improvements. This is an important point. You can't just talk about innovation, something new, something bright, something that's repackaged. We need to talk about innovation that is really something new and different and an improvement in care and treating somebody new. So I think that's an important conversation I haven't heard us talk about yet in terms of innovation. And again, while there's not a cure for MS right now, getting on a therapy early is most important. So we have to stop the things that are getting in the way of people getting on the medication that they need. And a lot of that's in the way is just the hidden costs, the things that are not transparent, that are not openly available. We can't see where the different, who's benefiting from these high costs of drugs. People with MS are not benefiting, we know that much, but who's benefiting and what's in the way of that. So just the discussions about how the system works or doesn't work and being really clear, having all the players together is something that we need to do that too.
Well, it does seem like since innovation is a critical part of this for as yet unmet medical needs, how do we build in a piece that's about focusing on the innovations that really do improve outcomes, prevent downstream complications, add a lot of value, and the steps towards transparency that you described could certainly help with that. I do think it fits though with this shift towards more of a focus around people and tracking and improving what matters to them, preventing the defects. But let me go to Peter to see if you can, you're on the front lines literally in a systematic approach and kind of cutting edge reforms and a systematic approach to delivering care. Can you help us tie all this together?
Yeah, or perhaps Mark, I'll try is to say, what Cindy says, innovation, at least I define it as ideas with impact. And we have to make sure the impact is there. And I think all of us, I don't want to speak for the panelists, but we didn't join Mark just because we're fans of yours and Research America. We did because we want to see impact. So I would ask the participants to submit perhaps what I call an I will statement. That is, what are you going to either start believing or stop believing to drive a defect in value, or what defect in value are you going to start making visible and design out of your systems, right? Because it's going to take all of us, across, the entire spectrum to get this, but we can begin today with each of us owning our piece of it.
We can. We unfortunately are out of time for the I will statements now, but I am going to take the statements that each of our participants made about what they wanted to see and the things they were willing to do to help get there as a foundation for that. But Peter, let's leave that challenge out there for everyone. We've talked today about so many things that don't get to zero defects, that aren't patient-centered, that are not holistic, that aren't focused about improving and innovating the outcomes that really matter to patients. But we did talk about a lot of steps to help get there. It may be pilots, it may be partial progress or limited progress, but I hope we can each agree to the I will keep working to do my part to make these changes happen. I want to thank all of you for coming together for this time on such a challenging and complicated set of topics and trying to bring them together. And with that, I'd like to turn back to Derek for closing out this session.